typing, you're moving, the fingers a little bit. Remember well, you're too young.
I remember typewriters. My mom had one.
Yeah. You had to, and people, mainly women, were in these positions of typing 8 hours a day on these things where you really had to bang on the keys. They didn't get repetitive strain injury. There was an epidemic of RSI in Australia in the 80s. It started rising, people talking more about it. This is very well documented, and people writing about it and doctors diagnosing it, and the rates just kept going up and up and up. And then finally the government said, what's going on? We're not paying for that. And all of a sudden the rate...
It makes me feel, is there an unintended consequence of doing this? I don't just mean with mental health, I mean with everything.
Yeah.
You want to raise awareness of things. You want to raise awareness that emotional pain, emotional things that we haven't processed can cause physical pain. But there is probably a sweet spot, whereas if we start talking about stuff too much, saying, that loads of people have got RSI, your posture and your computer's causing problems, you hear that more, that becomes your reality. There's a potential problem there, isn't there?
Well, there's been a long, long history, and there's a great book by Edward Shorter called From Paralysis to Fatigue, where he examines the history of psychogenic type illnesses over last 200 or 300 years. And he talks about how in different societies, different symptoms tend to arise as a cultural phenomenon. Right now, anxiety and depression are cultural phenomenon. Young people, look at the rates of anxiety and depression in teenagers now. The rates of back pain. There was a study recently where 1/3 of teenagers reported having back pain. And when I studied pediatrics and internal medicine, when I studied pediatrics, no teenagers had back pain. It was unheard of. If a kid had back pain, it was an emergency situation because there was some major problem. And so I have a friend who's from Iraq, is a physician, and he's here. We were talking, a great guy. I was saying, what was surprising about you when you came to the U.S. about medicine here? And he said, back pain. And I said, why is that? He said, well, people didn't have back pain in Iraq or Jordan where I practiced. It was very uncommon. People had stress, but their stress was manifest in different ways because culturally there were different outlets for it.
Sorry to interrupt. If you are enjoying this content, there's loads more just like it on my channel. So please do take a moment to press subscribe, hit the notification bell, and now back to the conversation.
And so when we think about these things on a societal level, and we think about how people are treated, how we treat each other, the thing that in longitudinal studies of people in workplaces and like factories, the people who are more likely to develop musculoskeletal pain, who are workers in a factory, are those who are being treated poorly by their management. And that's been shown, not how much work and physical activity they're doing, how they feel about their work and how they're being treated.
Did you not share a study once, I think, about how well back surgery is going to go for you? Something like that, I think.
There's a study on how well back surgery will go for you based on childhood adverse events.
Wow.
So people who had 0, according to the ACE scale, right, the Adverse Childhood Events scales that Fellini put together in the 90s, people who had 0 had 85% chance of having a successful surgery for their backs. People with 1 to 2 had 1 to 2 of these adverse childhood events, like abuse, neglect, alcoholism in the family, etc. 1 to 2 had 75% chance of having successful back surgery. If they had 3 or more, they had 15% chance of having successful.
Wow.
And there was no difference in the surgeries or their backs. This had to do with adverse childhood events being powerful forces that were still affecting them all those years later.
What you said about culture and how we have different cultural expressions of our stress and our emotions, it really rings true, that. And I think it's something that medicine, and I'm obviously biased by my experience here in the UK, because that's where I practice, that's where I've trained. I'm not sure we take that seriously enough because we get taught how to take a history. We ask a certain set of questions. That's great if the patient has the same understanding of what those questions are designed to elicit. Great then. But for example, in some cultures, they just don't have a word for indigestion. It just doesn't exist. If you don't have a word for indigestion, you may be suffering from something, but it may manifest in a different way, in a different physical symptom, a bit like your colleague from Iraq was saying about back pain.
Yeah. Yeah, there's been some studies about, I think the word is granularity in language, and how people use language in a granular way, meaning more granular, meaning having, is it an ache or a sharp or a hurt, or is it on an emotional level? Is it more rage or contempt or annoyance, or the language that we use for things can be very specific and granular, but it can be very broad. It's like it just hurts, it just feels bad.
Yeah.
It just feels bad. But that's communicating. There's something bad. There's something bad. And that's if we have an open mind to looking at, on one side, the medical and the structural, but also on the other side, the psychological and what people have to cope with and deal with in their life. It makes sense. Yeah, you feel bad. Well, we'll do some tests, make sure there's nothing actually structurally wrong. But what is this bad? What does that mean, bad? And what's going on in your life that might make you feel bad that maybe we can't change, or maybe some things can change. A lot of things you can't change in life. But how can we help you be more at peace?
Yeah.
And it would just when I say those words, I think about, your dad, going into there's a peacefulness, and maybe he was at peace as well. If we can somehow find peacefulness, in our lives, and if we can somehow find peacefulness in our societies that are so torn apart, that's what's causing suffering.
Yeah.
But it's manifest in this physical ways, and go to doctors. Like, doctors are the ones to solve these problems. Doctors are not well equipped. I was in Australia last week and giving a lecture, and there was a GI physician there who'd spent his whole career seeing people with irritable bowel syndromes and doing diets and medications and things like that. And he heard my lecture and he said to me, "Howard, your lecture was depressing to me." And I go, "Why is that?" He says, "Well, I realized that I'm very ill-equipped to care for these patients. I don't know how to do that because I've been trained in this whole other way."
Yeah, but that what he said, though, I have a lot of respect for, because at least he had the courage to say that.
Huge.
And accept that and acknowledge that. It's interesting how this morning, and this was in preparation for talking to you, I phoned up one of my best mates, Steve, who is a brilliant spinal surgeon on the south coast of England. And I said, "Hey, mate, listen, I'm talking to Howard Schubiner later. We're going to talk about chronic pain. You see a lot of pain. In your view, what is the most important therapy you give your patients with chronic pain?" Because, he's a super specialist. People who've got chronic pain who can't get better get referred up to him. And you know what he said to me? He said, "The most important thing that I do for my patients when they come in to see me is I listen to them and I show them empathy." And it was really profound for me to hear that. I mean, he's a great guy. He's a brilliant surgeon. He goes, "Look, surgery is great for acute cases where we can see something's going on, but for a lot of the time, we just don't need to do it for these people with pain. What they need is to feel heard and validated, because often by the time they come to me, no one has ever heard or validated their pain, their symptoms, that it was real." And he goes, "The truth is, with chronic pain, for me as a surgeon, it's a lot more touchy-feely." That's exactly what he said to me.
Yeah.
And he goes, "All kinds of things kind of work, but what I can offer is honesty, but the surgery probably will not help them, and then listen and empathy. And I thought that was really powerful.
Yeah, I mean, don't do something just to do something, because you can make it worse. You know, there's a saying in surgery: when you operate on pain, you get pain. But to be honest and to be open and to be empathic. And now what we're saying is that this touchy-feely stuff, it's not hocus pocus. It's not what we would say woo-woo.
Yeah.
It's neuroscience. And we're talking about the neuroscience of the brain.
Yeah.
And why these things happen. And we have data showing that people can get better. And we have data and we have techniques. And we can train doctors and we can train therapists. If you're a psychotherapist, a psychologist, or a social worker doing therapy, 50% of the people coming to you for anxiety or depression also have a chronic pain condition. And the question is, who should be caring for these people with chronic pain? It should actually be the therapists, the behavioral health people, because they can take the time and they can develop the skills. Your surgeon friend doesn't have the time. He has the skills to be honest and have integrity and not operate on what he shouldn't, and to be caring and empathic and listen. He can do all of that. But he can also learn how to talk this language of the brain causing pain, how to assess and say, oh, your pain is shifting and moving. That means it's not due to this disc here.
Yeah.
This disc would cause pain going down your leg. You don't have pain going down your leg, right? He can tell people that, that's what we do, right, in the assessment.
Yeah.
And then maybe he can point them to, there's a bunch of apps, there's a bunch of online programs, and we're training physicians, and we're training nurses and psychotherapists and massage therapists and acupuncturists, and we're training folks how to do this pain reprocessing work and how to do emotional processing work as well.
I mean, it's incredible what you're doing. And, as I've already said, you're doing research, which is giving this a real scientific robustness, which ultimately is what's needed if we're going to change the profession. I want to get into some of these therapies in terms of what people can actually do. Before we do that, there's two cases I've heard you talk about before, which I think are beautiful illustrations of how powerful the brain is in generating pain. One was, I think, a chap who had been in the Vietnamese War, and 20 years later, something happened on a street.
Yeah.
The other was a UK construction worker.
Yeah.
I don't know if you remember those cases.
Of course.
Would you mind sharing them? Because I think they beautifully illustrate this.
Yeah, of course. I always tell the three pain stories.
Okay.
The first pain story is a friend of mine who was at a construction site alone, shot a nail in his hand, had no pain. Why did he not have pain? He has a nail in his hand. Well, I don't know why. His brain decided not to turn on pain at that moment, probably because he was all alone. His brain had to decide, look, be in pain and suffer or drive to the hospital.
Right.
His brain said, drive to the hospital. I mean, I can't speculate why that is.
But he had no pain.
He had no pain at all.
Yeah,
in his hand. Yeah, exactly. So not all injuries cause pain.
Okay.
Number two, it's a guy in Britain, a construction worker, jumps off a scaffolding onto a nail sticking up in the ground. The nail goes completely through his boot. He can see the nail sticking out on the other side of his boot. He starts screaming in pain. He has severe pain. They rush him to the hospital. They give him IV pain medication when he gets there. And they take his boot off, and the nail is right between his toes. There's no injury at all.
Wow.
Is this pain real? Yes, because all pain is real. All pain is created by his brain, and his brain predicted, and the science of the brain is called predictive processing. His brain predicted that he should have pain based on the nail. It just made an error. But it created this pain, and the pain is real. Never underestimate the power of the brain to create severe symptoms, severe pain, severe fatigue, severe seizure-type activity that we see all the time. That's actually due to the brain, called paroxysmal non-epileptic attacks. And we know that because people are having these, looks like seizures. And the neurologists are there they know how to treat seizure disorders, but they put them in the EEG machine while they're having the thing. They monitor them, and then the EEG is totally normal while they're having this seizure activity. It's not a seizure. They don't need medication. they need to understand that they're not actually damaged. They need to do these kinds of therapies we'll talk about. So
that's the second case.
That's the second case. Yeah, thanks for getting me back on track. And the third case is the guy, again, somebody I met who happens to be a physician now, but he was in the Vietnam War as a young man. And he got injured with shrapnel wound. A lot of guys died. There was a lot of gore. And he got helicoptered out and medevaced out. So he had pain from the shrapnel wound. What happened to his injury? They healed. Why? Because all injuries heal. So his injury healed. Now, did his brain turn off that danger signal and make his pain go away? Yes, he was fine. He was pain-free.
For what, 15, 20 years?
Yeah, 20 years later, he's walking down the street. He gets startled by the sound of a helicopter in the sky. And all of a sudden, he gets the same pain in his leg that he had 20 years earlier. That neural circuit for pain had been learned, had been remembered, and then had been activated through a triggering response. And that's part of our assessment that we do to help people see that, gee, why is your pain occurring when you sit in that chair but not that chair? Why is your pain occurring when the wind blows? Why is your pain occurring when the weather changes? Why is your pain occurring in cold? Or why does it go away when you take a shower? Why does it... All these changes that we're looking for to demonstrate these neural circuits. So this understanding of how the brain works and predictive processing is critical. And we're not taught that in medical school.
I mean, they're very, very powerful cases to just illustrate what you're talking about the brain generating the pain. It's all the brain. Yeah. So we need to retrain the brain to eliminate it and help people heal.
Yeah.
Now, I know so many people will be suffering, or they'll have loved ones who are suffering with some of the chronic pain symptoms and conditions you've mentioned. I would strongly recommend your book, Unlearn Your Pain. That's for patients, isn't it? That's for people who are struggling. I think it's really easy to read. It's got the research. It's got some really great practical exercises in it. I think you also train healthcare professionals. Where can people find out about that?
Yeah, absolutely. We do have a book called Hidden from View, which is for professionals. We also have 2 other books we've written that are compendium. One is a textbook of psychophysiologic disorders. That's available through the Psychophysiologic Disorders Association. Here in Britain is SIRPA, SIRPA.org.
That's brilliant,
Yeah, do great work here. And then we've got trainings that we're doing, virtual, live, and recorded trainings. We just launched a mobile app to train people. It's called oviddx.com.
Okay,
oviddx.com. Yeah, oviddx. That's the name. Ovid, was a Roman poet who wrote, "When the mind is ill at ease, the body suffers." That was one of his quotes. And
it says it all, doesn't it?
Says it all.
A big theme throughout this conversation is that emotions, unprocessed emotions that get stored inside of us that we don't do anything with, can, in some individuals, generate pain.
Correct. What happens is we respond normally with fear of them. There are 6 F's. Fear of them, worry about them, worried of what's going on, focus on them, paying attention, monitoring all the time, fighting them, trying to push back, which gives them so much power, frustrated by them because we're angry and upset, trying to figure them out, going to all sorts of practitioners and therapies, and then finally trying to fix it. But the harder we do all those things, that gives the brain the message there's a problem, and it makes it worse. So this vicious feedback cycle of pain and other symptoms leading to these responses, the 6 F's, fear being one of the most important, leading to more pain. So when we interrupt that cycle, which you did when you lifted your mom that time when you told yourself you were okay and you smiled, you interrupted that cycle. You just interrupted that pain cycle by giving the danger signal in the brain these calming and safe messages. And that's what pain reprocessing is at its core. And we've got a whole bunch of techniques of how to do that so that people can, step it, do this, change your relationship to the symptom and see what happens. And then when you start investigating, looking, oh, hey, it hurt then, but it didn't hurt then. Oh my God, it is my brain. oh my goodness, I'm going to be okay. And then there's that relief.
I imagine even that knowledge alone, even if you do nothing else, even when the penny drops inside you that, wait a minute, this is nothing serious physically, this is not anything structural, I'm okay. Like even that must also help in and of itself, I would imagine.
Well, I started this work in 2002, and I read a book by John Sarno, Dr. Sarno, right? And Dr. Sarno has passed away. I just got an email from his daughter yesterday, and she's a therapist, and she's doing this work, carrying on. And anyway, it's beautiful email. And he taught me, and I've been doing this for almost 20 years now. Well, I guess 20 years. And his books are still bestsellers. Dr. Sarno's books, which state this, and he was brilliant in how he thought about it. He keeps getting bashed. Like,
I know.
Everyone loves to bash Dr. Sarno. So I'm here to
find his corner.
He wasn't right about every little detail, but Einstein wasn't right about every little detail. Come on. Anyway, but people will read his book and then the pain will go away just from the knowledge. And it's called The Book Cure. And it's happened, many. And there's a documentary on Dr. Sarno. There's a couple documentaries to mention. One is on Dr. Sarno called All the Rage, produced by Michael Galinsky. It's great. It's just a great picture of him. And then there's a documentary Kent Bassett and Marianne Cunningham made of my work called This Might Hurt. So there's a couple documentaries out there. And there's a new one coming out soon, hopefully, called Brain Pain, which was a documentary done about the Boulder back pain study that I was telling you about, right? So there's some films that people can watch to really kind of get a firsthand glimpse of some of this work. But yes, the answer is yes. Just knowing that you're okay can, in maybe 10, 15% of people, just turn off that danger signal.
Where do things like journaling and meditation fit in here?
Yeah, so once you've done the understanding part of it, and then you start doing this pain reprocessing part of it, of lowering the fear reaction, beginning to start moving again and challenging any of these triggers by smiling at them. It sounds silly, but, the pain is not the enemy, is our message. So if you have a child lying in bed fearful of a monster in the closet, you're not going to be mad at the kid, hopefully. You're going to open the closet door, say, look, there's no monster. You're okay. Lie down with them. Tell them you love them, that you're okay. Read a story, get them to laugh. They'll go to bed, right? That's how we're treating the brain, because the brain is just fearful. It's worried about you in the sense of causing these symptoms. When a kid falls off a bike, they look to you to see if they should cry or not. And if you freak out, they cry. But if you smile and say, oops, that was fun, then maybe they don't. So this is this pain reprocessing part. Now, meditation can fit into that because we use mindfulness meditation type practices in this work. And mindfulness meditation, I've been teaching mindfulness since 1999. And everyone should learn mindfulness. There's no one who's studied mindfulness who doesn't agree with that. Children, everyone should learn it. But the fascinating thing, Rangan, is that in research studies, mindfulness has not been particularly helpful in reducing chronic pain. Why is that? Cognitive behavioral therapy is not particularly helpful. Acceptance and commitment therapy, not particularly helpful in actually reducing chronic pain in randomized controlled trials. Why is that? Because none of them are doing the first step of the assessment of categorizing the pain into a neural circuit problem as opposed to a structural problem. So when you do mindfulness, you're noticing your sensations in your body, but it hurts, it's painful, it's uncomfortable, and you're interpreting those sensations as being dangerous because there must be something wrong with you. You're not getting better.
So you have to reframe first.
Yes. You have to recategorize the symptom into basically, and this, again, I'm doing this saying this word with love and compassion. And the reality is that this symptom, this pain or whatever it is basically a thought. It's basically created by the brain. And now if you can observe that, now you can step back from it and observe it. and just watch it and not try to fight it and be frustrated by it, but set that aside and then be with it and see what happens. And then maybe it shifts. Maybe it gets a little worse. Oh, my brain just made it go up. Oh, that's interesting. What's going to happen next? Oh, it just went down. Oh, that's interesting. Oh, it moved over here. Okay. And all of a sudden you see, and then it really, as you said, it drops. All of a sudden you get it. And then, so meditation has a really important role in this, but not just meditate.
Yeah.
Understand and use the tool in a way which is going to help reverse the pain as opposed to cope with it.
There's studies on yoga, I think, as well, aren't there? That yoga, deep breathing practices, whether as part of yoga or not, can help change our perception of pain, I think. There's quite a lot of studies on that.
Sure, of course, because what you're doing is you're making yourself feel safer. You're calming the danger signal, the autonomic nervous system responses and all that sort of stuff.
Yeah.
You're calming it, and you're giving yourself a sense of control that you can do something. And yoga, of course, is beautiful because you're pairing that with movement. You're pairing the calming and the reassurance and the joy with moving your body. So neurons that fire together wire together. So when you're moving with fear, you're reinforcing these neural circuits of pain, fear, pain. But when you start moving gently with calm or with joy or with control or with peacefulness, now you're training your brain that these movements are not dangerous. And those neural circuits start to get ingrained.
I wrote down this quote that you have written in an article. Over the past decade, I've learned that migraine, along with other related conditions such as chronic tension headaches, pelvic and abdominal pain syndromes, chronic neck and back pain, are often caused by a combination of life events and emotions that are neither expressed nor processed. All of these conditions are associated with early onset of, I think, symptoms, which sensitizes the danger signal in the
Early
brain.
onset of stress, like adverse childhood events, probably. Yeah, which sensitizes the brain.
That's the key, isn't it? It sensitizes the brain.
Yeah.
And as you say, the yoga or the deep, slow breathing is switching off the stress signal, saying, hey, I'm safe,
Exactly.
I'm okay.
Right. But then we can get into the emotional side of it, because you mentioned journaling. So journaling is part of the techniques that we would use on the second part of the treatment, not the pain reprocessing part, but the emotional awareness and expression therapy, which we've developed and worked on. It has components of intensive short-term dynamic psychotherapy that my friend and colleague Alan Abbas is the foremost researcher and teacher in the world on that, plus some internal family systems work as well. So if you put kind of those things together, you start to deal with the emotions of it. And that's a whole nother area that can really lead to healing on the inside.
Yeah.
Not just recovery from the symptoms, but using the symptoms as a way to decide what's important in your life. So that's a whole nother area that we can discuss as well.
How much does our personality type influence whether we're going to suffer with chronic pain? And I guess why I'm thinking of that is if early life trauma, if ACEs are hugely influential in what's going to happen later on in life, including with chronic pain. I've had 3 conversations with Dr. Gabor Mate on this show about how our childhoods can affect our adults' experiences, how we are when we get triggered by our partners, all kinds of different things. But often we develop certain traits, certain personality traits that are not really who we are, they're who we became to get through childhood, So poor self-esteem. So, being a people pleaser, wanting to do things for other people, right? Those personality traits, as I believe, as Gabor believes, are not necessarily who people are or who they have to remain.
Right.
If they go and do the emotional work to actually go, oh, actually, that was a defensive mechanism that I took on to help me through childhood. I want to let go of it now that I'm in adulthood. It's no longer serving me. Do we see patterns? Have you seen patterns in your clinical practice of certain types of people who tend to be the ones who suffer with a lot of these chronic pain syndromes?
Yeah, there's no question about that. There's really kind of three ways to think about it. One way is we are actually born not blank slates. There's been really nice studies of children and temperament, so to speak. Some kids are more sensitive than others. Some kids are shyer than others. You can breed sensitivity and shyness and fearfulness into mice by doing genetic breeding studies. So there's some stuff that we actually are born with. But the longitudinal data on that shows that those change over time. Some kids are very sensitive. My daughter was super, super sensitive as kids. Now she's lecturing around the world. So, there's that. But what you're addressing is more important, which is the acquired personality traits. And those are highly connected to later life pain and other of these type of neural circuit type problems, for sure. And the reason is like you say, they're adaptive. If your dad comes home every day and sometimes he's really nice and kind and sometimes he's really angry and critical, you learn to be on edge. You learn to be a people pleaser. If your sibling is sick and they're getting all the attention in the family because they're sick, they've got leukemia or they've got bad asthma or whatever, or they've got a mental illness, well, you learn to get into the background and be a people pleaser and be a perfectionist and be always being good and putting yourself last because everybody else matters first. And these are adaptive techniques that get you by, but when you get on into adulthood, sometimes your brain is going to say, like, what about me? What about you? How come you're putting yourself last all the time? And that's putting more pressure on ourselves, more pressure on this danger signal. And so that is an important component of this situation or this condition that oftentimes people, as you say, can address and can begin to change in them. So it's not that you shouldn't be good or you shouldn't be kind. It's just that you also have to stand up for yourself sometimes. Sometimes you have to learn to say no. It took me until I was 50 until I could say no. It took a long time.
I think it maybe took me until I was about 42. So hopefully the generation below us will start to do it earlier.
I like to say it's a magic word. It has two letters, an N and an O. But not it's the human condition to have some of these things, of course. Yeah. So it's just part of the mix, and each person is unique and individual in terms of how that mix plays out in their life.
Howard, I honestly think what you're doing with your clinical work, with your research, is a great service to humanity. There are so many people struggling with this. This is a topic we've never really covered on the show at all. So I'm so delighted that we finally got to cover chronic pain in all its many different forms, in all its different guises. I feel that what you have done, certainly to me, is help people feel less alone. That actually, no, your pain is real. Yes, maybe your doctors haven't found anything structural. Maybe you think you're going crazy with pain, but you're not. Mm-hmm. It's just that no one's helped you yet get to the root cause. If you want to solve anything, you need to get to the right cause.
Exactly.
I'm hoping there have been some penny dropping moments for people in this conversation. There are a lot of people, Howard, who, where do painkillers fit in here, in your view?
Well, when people are suffering, we want to alleviate suffering. That's part of being a physician, part of being a caregiver. So Dr. Sarno kind of had an idea. He wanted people to throw away their pills, throw away their crutches, throw away the things that are helping them cope, which is fine when you have that amount of confidence and, it's not too bad. But, some people need pain medications, certainly if they have ongoing, if you have metastatic cancer kind of situation, doctors have gotten worried about giving strong pain medications to people who are dying of cancer. I mean, that's silly. Why should we not alleviate suffering in that way? And if someone's suffering with severe pain due to a neural circuit type problem, they may need pain medications while they do this work, certainly. And so I don't want people to feel like they can, never take a pain medication. But if you can alleviate pain with pain medications temporarily while you start investigating your life, while you start the pain reprocessing work, while you start dealing with some of the emotional situations in your life, then over time you can reduce the pain medication.
Yeah.
One of the problems we've had in the medical profession recently is people are put on forced reductions of opiates and saying, okay, you're going to taper. And what happens is now you get what's called, as I'm sure you're aware, the nocebo effect kicking in. So people are fearful that their medications are being taken away from them forcefully. And now the pain is going to be worse because the brain is put into a bigger state of fear, and lowering the medication is much harder. So what we try to do is we try to first just stay on your medication. Let's see if we can get you out of pain first. If we can get you out of pain using these methods, then tapering that medication is going to be easy.
I guess this speaks to personalization, doesn't it? If a patient rocks up at your door and they've been on painkillers for 10 years, they think that they're helping, you got to take a different approach from, let's say, someone who's coming into you for the first time, where with this new information, hopefully, you can actually set them on a different path. And I think this is why I think healthcare professionals need to understand this stuff, because we can be hugely influential in what that patient believes when they walk out of that door. I've always said, migraines are really common. My preference is always to try and help patients get to the root cause so they don't need any medications. But sometimes a patient, you got to meet them where they're at, first of all. And sometimes it is so bad that maybe in the short term, you give them something, but you also need to make it clear, in my view, that, hey, listen, this medication is not going to help us get rid of this. It's simply going to help you manage this so you can tolerate your work at the moment. But I can also help you, if you want, try and find out what's causing this. I don't think that second part of the conversation is often had. I know the time of consultations, certainly in the UK, doesn't make it any easier, but it's not just that.
Right.
It's not just time. I think time's the easy thing to say. It does play a huge role, but I think our understanding is simply not there as well for this. I don't know about you, Howard. I've often found with some of these patients in chronic pain, though, that they're taking huge amounts of medication and they're still in pain.
Right, for sure. What we're doing is the Band-Aid technique, the coping technique, and we keep adding on to that more and more and more. And we need a different path. There's no question about that. But we can't force this path on people either, because you said the words, if you want.
If you want.
If you want. Because what we're doing is we're offering, and we're, as you say, we're meeting people where they're at. And we're meeting with empathy and kindness and caring and understanding. And a lot of people, not a lot, I mean, most of the people who come to me understand this. That's why they're coming to me as a physician. But, sometimes they don't, or, it doesn't really make sense to them. And I'm like, fine, this may not be the right path for you. Yeah. There are lots of other paths to healing. There's lots of other ways of healing that could be, all sorts of stuff in the alternative fields or whatever. I try to be careful of that, and I try to help people not spending too much money or, getting on other diagnoses that don't make sense. But there's lots of other paths to healing, and maybe there's other medical paths that you haven't tried yet. Let's sort it out, Isn't that what you say here? Let's sort it, and let's just take it step by step, and let's see what happens, and let's investigate. Once you have this kinds of information, now you can look at what's happening over time, and you can look for those experiences that you can have which show that, the pain, this happened in my life and the pain went up, or this happened in my life and the pain went down.
Yeah.
Or it's inconsistent. Why is it happening sometimes and not other times? And now that you have a framework for understanding that, you can say, maybe it is my brain after all. Wow, wouldn't that be something?
Yeah. Howard, this podcast is called Feel Better, Live More. When we feel better in ourselves, we get more out of our lives. And clearly, pain is something that makes people feel worse. It affects every single aspect of their lives. For people who are listening, who are watching, who are struggling in their lives, they're struggling with pain, or someone close to them is suffering with chronic pain, do you have any final words for them?
Well, I think the starting point has to be compassion and caring and understanding. And if we can strip away some of the fear and some of the pejorative words and it's all in your head, if we can strip away the way that sometimes people are treated in being treated, in that pejorative way. But if we can also strip away some of the diagnoses and some of the words that people have been given, like incurable and bulging discs, and the names, it's chronic fatigue. And there's so many names. I don't know if we have time to get into it, but so many names have been given to people. Oh, you've got chronic Lyme disease. You've got Ehlers-Danlos syndrome. You've got, your posture's all bad. All these things, if we can just start over, strip away the unkindness and strip away the incurable and start in a middle place with investigating carefully and taking time to look at people's lives and look at their symptoms and see what you can find.
Yeah.
Because when you do that, usually you'll see, maybe there's something here that we can work on.
Yeah. Just on that point, you mentioned chronic fatigue, chronic Lyme disease, these kind of things. And I don't want anyone to go away from this conversation feeling there at the end that, hey, so I don't have that, or I do have that, and Howard Schubiner has just said, forget about that. I think it's really important that we help people understand that. What exactly did you mean by that? Did you say those things are not helpful, or are you saying that, look, if you've had that for a while, temporarily, why don't you just park that, start again from scratch, evaluate it as if nothing had happened before? What exactly did you mean?
Yeah, let's evaluate it. Like I say, as physicians, everyone needs an individual assessment.
Yeah.
And do you really is it really chronic Lyme? Let's look at the tests and let's look at the symptoms. With long COVID, if you look at the symptoms very carefully, I saw a woman and there's a lot of research on that now, research showing that people with pre-existing anxiety, depression, loneliness, fear are more likely to get long COVID than those who don't have that prior to getting COVID. There's research showing that people who didn't have COVID had as high or higher rates of long COVID as people who actually did have COVID in a large French study. And if you just take each person as a unique individual and just look at them, talk to them, do the testing, if there's no explanation for it medically, and the symptoms are brain fog and fatigue and aches and pains and diarrhea and headaches and anxiety and depression, and it's all there, what's the harm in looking at it closely and looking at it from this lens of neural circuitry? What's the harm in just looking at it? I had a patient who had long COVID, young woman had it for about 1.5 years, really bad, and she saw me, just one visit, and 2 weeks later, she was 80% better. It was amazing. But what was really interesting is she had loss of taste and smell, which is part of COVID, right? You get COVID, you get loss of taste and smell. That's got to be a structural problem, right? I mean, how could it not be? Well, she had loss of taste and smell for 18 months, and then I saw her one day, and then the next day, her taste and smell returned. And then the day after that, it was gone again. And then it returned again, and then it was gone again. Her brain had the capacity to turn on and turn off this thing, which seems completely neurological, and it's certainly real, but the power of the brain is immense. And if we're just open to that, that's all I'm saying is I'm not judging people or assuming that what they have because of their label is or isn't real, but it's taking the time to investigate it in a careful and compassionate way. That's what I'm trying to say.
What did you do with that lady?
Oh, well, just what we do every day. We went over her whole life and the story, linked stressful life events to her situation, looked at the symptoms that she was having, the brain fog, the fatigue, all the testing that she had, making sure that there was nothing structural wrong. And then we started having her change her relationship to her symptoms, knowing that she could get better.
Yeah.
Starting to smile, starting to move, starting to reassure herself little by little. And that is what, and then she saw the symptoms shift, get better, get worse. And she said, oh my God, it is my brain. And then they started getting better.
Yeah, it's so powerful. Whenever I am faced with a patient who's accumulated lots of different diagnoses and labels, I will often take that approach. Okay, let's just put them to the side for a minute. Let's just go back to basics. I did this very publicly on BBC One in 2016 with a lady who I've actually spoken to on this podcast in the past who had fibromyalgia, she had ME, she had, I think, 10 different diagnoses, including anxiety, IBS, depression. Mm-hmm. She had everything. All the buckets that we can give you in modern medicine, she had been given all of them. She was on 20 pills a day. I've got many other cases like this, but this is one that the public saw. Millions of people saw this case. And I remember saying to her, with the cameras rolling, look, let's just put them to the side. You know, you picked, I think we use an analogy for truck, you know, you just picked up all these kind of carriages and you're walking around your life with them. You're on 20 pills a day, you're still in pain, you can't work, you can't be a mother, you can't be a wife the way you want to. Let's just start from scratch. Let's just focus on you as an individual. Let's start creating health in you. And so this is often how I approach things. Instead of, it's not saying that those are all wrong. It's just saying, instead of focusing on what's wrong with you, let's just see how I can help create health in you with, you know, emotional stuff, sleep, stress, movement, whatever it might be.
Yeah.
And as we did that, 6 weeks later, she was pain-free.
Yeah.
Pain-free. And then 2 years later, so this is after the show had finished, 2 years later, she's on 0 pills a day.
Yeah, amazing.
And I say that you will have seen this many times in your clinic, but I say this to leave people with a message of hope at the end. It's not that we're saying that's not real. It's just saying maybe we need a kind of different approach.
Yeah, yeah. The power of the brain is immense. The power of our connection to each other, our social connection, the power of what goes on in our lives is immense and has tremendous impact on how we live day to day. And there's just so much suffering in the world. So much suffering that I think we can do better. And I think we're just trying to point the way little by little, step by step, to doing a little bit better. And you're doing this work and you're helping in this, in your work and in this kind of work. And everybody who sees this work, every patient that I see, they ask this question: how come my doctor didn't tell me about this? How come people didn't know about this? How come I never heard about this in the last 5 years or 10 years or 20 years of suffering? How come nobody told me that there was a different path? And it's not for everybody. And I don't expect that everybody who's listening is going to like, oh, yay, you know, we found the way. But some people will.
Yeah.
Some people will. I guarantee that.
Well, Howard, you're a huge part of this change in thinking about pain that's going on all across the world. I hope, like you, that it speeds up and gets out to more and more people, more and more healthcare professionals. Thank you so much for all the work you're doing. And thanks for coming on the show.
Thank you. It's a pleasure and an honor. Appreciate it.
If that conversation about chronic pain resonated with you, I think you are really going to enjoy this powerful conversation, all about the common reasons that many of us feel lost and unhappy.
Addiction is the most human thing there is. All addictions, the attempts to gain pain relief, emotional pain relief or something or another. Then this whole society is so expert at selling us stuff to fill those holes temporarily. This is the whole ethic of this culture.